Thank you very much. We're going to finish this session with the effectiveness of physiotherapy for management of the glenohumeral osteoarthritis. As the previous speakers have denoted, it's a difficult case and very complex in presentation. So it's a progressive loss of articular cartilage resulting in bone erosion, pain, and decreased function. It's the third most common large joint to be affected following the knee and hip. The true prevalence is difficult to ascertain because there are patients with very mild symptoms not consulting. From population-based studies, we see a prevalence of between 16 and 20% of adults older than 65 years old. They have radiographic evidence of glenohumeral OA. Now, the rate of progression is also impossible to predict, with cartilage loss occurring over months to years. The cartilage loss does not necessarily correlate with patient's symptoms. There are very bad cases like this one, which we cannot really say we can improve. There are well-established risk factors: age, female sex, Caucasian race, and obesity. The secondary causes include avascular necrosis, infectious or crystalline arthropathy, prior trauma, such as dislocation, and prior surgery. The age of trauma also is important. The presence of rotator cuff tear and presence of bony defects of either the glenoid or humerus, which are also important and make the clinical presentation more complex. Also, we have rheumatoid arthritis, which is characterized by earlier onset of disease, more rapid progression, more severe osteopenia, and primary or post-traumatic glenohumeral osteoarthritis. It affects the shoulder in more than 90% of patients with greater than 5 years of rheumatoid disease. It must be differentiated from rotator cuff arthropathy, which has a different precipitating cause and a distinct treatment algorithm. And now in primary glenohumeral arthritis, the limitation in shoulder movement, the loss of joint space, the presence of humeral head osteophytes, and the absence of rotator cuff tear are the main clinical picture that we are called to treat. The pain is often localized posteriorly and deep within the joint. It is typically associated with night pain, stiffness, and functional limitations. Now, there are the very recent guidelines for the summary of best practice statement recommendations from the American Physical Therapy Association that have come out this year, which show the strength of the recommendations of physical therapy, which is not very strong, but there is some evidence, scant, that shows that preoperative physical therapy for patients scheduled for TSA is effective, depending on the clinical presentation, and that if they are delivered preoperatively, they may benefit postoperative outcomes of patients with arthritis which are undergoing TSA. Now, for the non-operative physical therapy, which is the main interest of this session, the comparison to other management strategies, it seems to be they're all equally effective. Physical therapy services may benefit patients who have not undergone TSA, and they're not superior, the interventions between them, from one another. Okay, this is after TSA, and after TSA, you have a new joint essentially, so you have a strong recommendation, just to make a distinction between the previous presentation before the surgery and this one. And for patients undergoing TSA, there is a very strong influence of postoperative management and physical therapy, depending on the sling and the exercise. There are no known interventions that demonstrably reverse the slow and natural history of early glenohumeral arthritis before the patients requested TSA. Over time, there's worsening pain and stiffness, which were called to improve. Often difficulty falling asleep or after awakening due to night pain. So these are outcomes that we need to be aware of. They're measurable outcomes, more important than the range of movement. The gray areas of range are the areas that the people with arthritis have, in contradistinction to the full range of movement that you see in the picture on the left. There are range of movement limitations that you see, and also one that you don't see is the internal rotation limitation because of capsular thickening and contraction of muscles. And the posterior wear also of the joint is also contributing to that. Now, the physical therapy strategies that we are using is passive and active stretching exercises and passive and active range of movement exercises to try to mobilize the joint and keep the available range of movement. These are only variations, a few variations that we use. And stretching and range of movement is often directed to specifically improve the internal rotation, the reduced external rotation, and the difficulty, it's function directed, so the difficulty in performing certain tasks. Again, variations of the same type of exercises. So a combination of passive and active motion exercises may be more beneficial than either technique alone. Improved range of motion alone is not sufficient to regain the ability to complete the ADLs, as strength is often lost without the progression of glenohumeral arthritis. So these are isometric exercises to isotonic to resisting exercises that we are using. Postural re-education is important because the scapula needs a stable base of support, which is the trunk upon which it can operate. So it's essential to stress in these patients the ergonomics, because you see, as you improve the thoracic posture, you improve the contribution of the scapula to increase the range of movement. There is manual therapy also, the idea being that if you improve the accessory movements of the joint, then you improve the range of motion and the pain. There's motor control re-education from very fine motor control exercises that have to do with the distraction of the joint on the left, and the patient has to contract the rotator cuff and other stabilizing muscles to put the humerus head back in. The dynamic rotary stability, which those two are also tests, but they're also used for treatment. The symmetric and asymmetric loading of the joint. Motor pattern re-education of the scapula. And also to increase adherence, mostly, we use, lately, there has been publications reporting on virtual reality and how they can be used for rehabilitation of patients with glenohumeral arthritis. So to conclude, the patient classification is necessary if we wanted to really understand the effectiveness of physiotherapy in different types of patients. The comprehensive physical therapy treatment strategies are needed for individuals with glenohumeral arthritis. Those are exercise approaches, home exercise, which has to complement the physiotherapy visits, manual therapy, education and advice, functional activities modification and re-education about those, and the use of virtual realities environments to improve adherence. Now, there are also follow-up booster sessions used that may be required to enhance the adherence, the psychology of the patient, and the patient-therapist communication. Thank you very much.
Thank you.